Hello and welcome to the West Coast Vascular and Interventional Symposium's Program Director panel. I believe this is our third iteration so far. On behalf of the WCVIS team, my name is Eric and I'm a fourth year student hosting the panel today. We have many medical students tune in this afternoon who are hoping to match into the integrated VIR pathway, and we're very fortunate today to be joined by a panel of program directors who lead some of the most clinical and the most integrated VIR training programs. Time permitting, we'd like to take some audience questions at the end. So first up, let's meet our panelists. First up, we have Dr. Vatakencherry. He's the program director of Kaiser Permanente Los Angeles, and he did his fellowship at UCLA. Next, we have Dr. Keri Connor, program director of the University of Oklahoma's program, and she did her fellowship at the Miami Cardiac and Vascular Institute. Next is Dr. Parag Patel. He's the program director of the Medical College of Wisconsin's program, and he's the immediate past president of the Society of Interventional Radiology. He also did his training for fellowship at the Miami Cardiac and Vascular Institute. Next, we have Dr. Kyle Cooper. He's the program director at Loma Linda's VIR program, and he did his fellowship at Miami Cardiac and Vascular Institute. And last but not least, Dr. Arsalan Saleem. He's the program director at UTMB's VIR program, and he did his fellowship at UTMB. Okay, so let's get started with some questions. I will be calling on individual panelists to answer the question at first, and then I'd like to see if we can pass around that question to each panelist before moving on to everyone else. So, first question is for Dr. Vatakencherry. How often and at what point during residency do your trainees go to VIR clinic?
Well, that's a great question. As you know from my other talks, that clinic is the first 6 letters of clinician. And so I've placed an emphasis on that. I've noticed that our graduates who don't do a lot of clinic don't succeed when they leave. So we institute clinic PGY 2-year, and half a day a week, no matter what rotation they're on, they go to their clinic. And the goal is to kind of have their own continuity clinic patients, so they follow them for the 5 years, and they learn a lot of natural history, on top of the patients that I've been following for now 15 years, that they learn natural history data. So the evaluation management is exceedingly important for our trainees. And the goal at the end is for them to start giving talks to get their own patients into the clinic. So I know Austin reached out about a small aneurysm to get into his clinic recently. And I think that's kind of our goal, is to start practice building during the residency training.
And just as a quick aside, sorry to interrupt real quick. If you're on the panel, I know that it's different levels of if you can actually have your video chat on or not, but if you are able to turn on the video, that'd be really appreciated. If not, totally understand, but just something else.
Yeah, I think everyone's on the video. Perfect.
All right, thank you, Dr. V. Do any of our other panelists have a response to that question?
Sure, I'll jump in. We have clinic. We've always had clinic since I've been in the practice at in the Medical College of Wisconsin. That is to say, all of our faculty have 1 day a week. There's usually 2 faculty in clinic any given day, 5 days a week, between our cancer center clinic and our non-cancer center clinic. And we have residents rotate with us on a daily basis. They don't have their own clinic structure or their own continuity clinic per se, that they run their own patients. That's just not how we're set up. But we expect and schedule our residents in clinic every day of the week when they're on rotation with us. So that starts from their first year rotations all the way up through their 6th year rotations. And it's part of their month on service, so to speak. Whereas the old school model was they'd spend the whole month in IR doing procedures. We rotate them where they have 1 day a week in clinic. Our clinic is fairly specialized as our practice has evolved over the last 16 years. So they might have a day where they're seeing a lot of vascular, arterial, venous, aortic, and another day where they're seeing musculoskeletal, another day where they're seeing predominantly IO or perhaps portal hypertension. So the flavor of that changes each day, and I think they enjoy that. And frankly, they'll see follow-up patients that they treated the week before, and they'll see new patients in which they'll treat in the coming weeks ahead on service. So it's worked out well, and it mimics a little bit of what we do, meaning I see clinic 1 day a week. I'm not in clinic 5 days a week or for a month straight. And that's where we're at now, is an evolution of what we've done, I'd say, over the past decade to try to best fit what our trainees want. I think, but also mandating a clinic experience, so they leave practice or leave training knowing how to run a clinic, knowing the importance of clinic and sort of the cornerstone of their clinical practice, or building their practice.
Yeah, I'd like to quickly jump in. I mean, I've been inspired by the way that Dr. Vatakencherry has set up his clinic in his program. And we've had clinic at Loma Linda for about 20 years, but the resident experience, or it was a fellow experience, was that they would actually leave the procedure space for the half day and cover clinic, and they were missing out on procedural opportunities. So I have started pulling residents, the IR residents and the ESIR residents, beginning in their first year to cover all clinics. So clinic experience is being covered by people who are not actually on IR almost completely now. PAs are helping out a little bit to fill in the gaps, which has been also helpful. But what I really want to do is emulate what Dr. Vatakencherry has, which is a continuity clinic, so that the patients become the residents and the attending is interchangeable. Again, it's Dr. Patel mentioned, you have to work within the confines of what each hospital situation is. So each clinic experience is going to be important, but I think you have to be looking for somewhere that is ensuring that you're getting a regular clinic experience no matter what.
Yeah, I agree. Our institution asks for a vascular anomalies clinic. So we do that once a month in addition to our cancer center clinic, which we do 2 days a week. So the residents typically will follow their own patients, especially the hospital follow-ups, PCNs or biliaries or things like that may have some longer term planning necessary. So they often will have their own private patients, and not, patients that they've never met before, and they can continue to see those throughout the need of that patient.
Yeah, for us here at UTMB, we're fairly new into the realm of clinic development, and we're continuously in contact with Geogy, and he's been mentoring us a lot. We're really, really thankful to him for that. We recently got our clinic space here at UTMB. We were not having a dedicated IR clinic, VIR clinic here at UTMB. Starting this last year, we've started doing 1 day a week of the clinic. We're still a little low in our faculty cohort, and we're developing our faculty cohort and also our clinic. So final goal is going to be where our residents are going to be running the clinic, and the patients are going to be resident specific, or it will be resident clinic, so to speak. But for now, it is being run by faculty, and we only have 1 NP, and the residents, including ESIR, are independent, and intervention, categorical intervention radiology residents are assigned to clinic. So, yeah.
Okay, thank you for our panelists for taking that first question. The next question, we'll start out with Dr. Patel. So we all know clinical skills are hard to grow and maintain. How does your program integrate VIR during those diagnostic heavy PGY 2 through 4 years?
Good question. This has also evolved slightly over the last 6 years as we've graduated our first groups of integrated IR residents. But it starts with our rotation schedule. We do have dedicated IR months in those first 3 years. Their intern year is integrated with our residency, so it's local. It's a surgical intern year, but it's on rotations that are interact with IR quite a bit. 3 months with vascular surgery, transplant surgery, interventional oncology, trauma, so on. And we interact with them on service or in their wards or units quite frequently. So they see us, they recognize us, perhaps on the IR side while they're on the surgical side, but there's a connection there. And then in their first 3 years in the IR residency, PGYs 2, 3, and 4, they do 2 months back-to-back of IR. So they have that touch point within the course of what is otherwise a long DR year. And then we have monthly touch points as well. So I have a monthly program director kind of connect with all of our residents across all 6 years. We have a monthly journal club that's topical based. All of them are invited. And frequently the junior residents are the ones that are presenting kind of background pathophysiology, and then the senior residents are presenting the critical journal article or topic du jour. And then we do, honestly, we do a lot of social sort of touch points within the residency. We've done some community outreach, we think that's an important component of practice in medicine, regardless of specialty. And we do, holiday parties and sort of the fun stuff as well. So I think the key to this is continuing to have them understand that their home is in IR, and that the why they went into the residency was to take care of patients and to learn the clinical work they do, and not get so sort of assume that 3 years of DR they're going to get nurtured in that fashion. So we've it's not just the rotation time in IR, but I think you have to invest in the individual and remind them of that. So that's our approach, or how it's been so far for us.
Would any of our other panelists like to take that question as well?
I'll add one more thing. Is the other thing our junior residents tend to do is we encourage them to go to meetings. I think interacting with their fellow trainees across the country is another great touch point for reminding them why they do it. There's an energy that IRs in practice have, and a similar energy that IRs in training have, and it can be contagious, and it's a good thing. And so rather than wait till they're, PGY 5 and 6 years to go to, big meetings beyond SIR, I'm talking about meetings like ISET or Viva, Guest, and so on. There are some great opportunities and trainee scholarships, frankly, for them to take advantage. It gets them a little bit out of the DR doldrum, so to speak, and has them connect with faculty who are frequently there from our practice, and then trainees around the country. So I think these are all small suggestions. I think collectively you have to have a plan, and it's not one thing, but it's the totality of it that really helps. That's been my experience.
Yeah, I mean, I have to echo Dr. Patel. Picked up some pearls from him, like how they have kind of industry kind of go over like aortic, product, et cetera, jointly. So it's something that we need to incorporate more of for my residents. Yeah, and we do morning lectures Monday for the general, but Monday morning we'll take up the 5 and 6, and we'll actually go to do a journal club just with the seniors together in the gym. That's something we started this year, and more advanced topics. And then we'll take Tuesday, we have vascular conference, which John actually runs. So he can tell you as a 2 how hard that is. And then every Wednesday and Friday, we have dedicated VR conference. So I think that's been very helpful for all integrated and ESIR residents. And as you said, you have to build a community. They do 2 months of VR starting PGY 2 year, half a day clinic weekly. So we're getting a lot of exposure with them. So at least 8 hours a week. And then on top of that call, John's been on call. He'll do 1 weekend a month to call PGY 2. And those things have been invaluable. Now you say you love it, but in reality, it's kind of painful to run these complex conferences and being grilled by surgeons and interventionalists who do aortic work. Anyway, so those are things that we've initiated, and I agree with Dr. Patel wholeheartedly that the bonding and the experience of going out to ISET and seeing very aggressive kind of core group and seeing, Katz and Ben, Benedetti win an award, and all this is very inspiring and keeps them on their path to the IR. And so we highly encourage that.
I like all of those techniques. One other thing that we have tried to do is to get them call experience. We buddy them up beginning in their first month of PGY 2. So they start going through a buddy call rotation with the PGY 5s and 6s that are basically fellows. And so they get opportunities to work up patients on the weekends, help with clinical stuff, and then, of course, scrub into cases that they might not otherwise get to see and participate in. So that's been really popular.
Yeah, for us also, it's kind of like a combination of what Dr. Patel, Dr. Vatakencherry, and Dr. Cooper mentioned. Our residents also start taking call from day one, the moment they hit the intervention realm out of their internship. Our internship is also integrated here into our program, so it is a 6-year program. Once they have cleared their internship year, they start taking call, and they're buddied up with their PGY5s and PGY6s from day one throughout the year. It is a rotating base call. In addition, they're also being called into the 1 day a week clinic, typically on Wednesdays, and they're assigned to the clinic day only, irrespective of the fact they're going to be on IR or not. That way, they are still in touch with VIR. Even in their internship year, they have 1 month of VIR. In addition, we also have Wednesday academic days where there are dedicated VIR conferences in the morning. It is a protected time for our residents. They are not operating during that time or doing any clinical duties. And we do have monthly journal clubs, which are actually sponsored by UTMB in addition to industry as well. And they are fully covered to actually go and attend different conferences throughout the year. They have protected academic time for that. They also have academic endowment funds, UTMB, which is an old institute. So we got a lot of money. They're give or take $14,000 per resident, which covers their lodging and travel and registration and everything for those residents. So it's highly encouraged, and we do so in our residents every year.
Do you have any pearls on this topic, Dr. Connor?
Well, we have an independent only right now, so we actually don't have it integrated. But every practice is different, and what's really nice about having independent only, we have ESIR as well. But our independent residents are, they get everything. They're not competing with integrated residents; they're getting pretty much everything. And so, we often where they come from. Sometimes we have non-ESIR residents, and sometimes we have ESIR residents that come into our program. But when you have mixed programs of integrated and independent, sometimes those independent residents feel like they're behind the mark because they often will be. They don't have the camaraderie that they've had for years with the other residents. They're kind of being thrown into the mix. And so when you have an independent residency that does not have an integrated program, you don't have that awkwardness. You don't have to have that competition with residents that have been here for, years. And when we assess each other, we have to make sure that they have the clinical skills that they've had in their ESIR year. But if they, sometimes the ESIR is amazing and they come in basically ready to practice. And so we'll bring people in and, just take what skill set they have and run with it. If they need more neuro, if they think they're going to be doing stroke call when they go out into practice, we can really, at that point, really kind of, make a bespoke program for you. You can do more neuro, you can do more vascular, you can do more oncology, you can do more pediatrics, or whatever it is that you need. And so it's really nice to really be, not, you can have anything. You have all the cream of the crop of the procedures. You don't have to compete with others for those procedures, and you get first pick, which is really nice.
One more small thing I want to add was and I think we started doing that starting this year after discussing with Geogy earlier this year in July, this academic year, was the fact that we started having all of our residents from PGY2 onwards, instead of doing just one VIR rotation, 2 VIR rotations a year. And we've done it such that they're due back-to-back 2 VIR rotations, not like very spread out. So it's like a very solid composed experience for them, so they stay in touch, because that's what I heard from my categorical residents, is that they feel very much attached if they're going through the first 36 months of radiology before coming into VIR. That way it has changed a lot, and we are keeping tabs on that with our monthly reviews from our residents, and we've been getting pretty good response about that, for sure.
Awesome. All right, next question for Dr. Cooper first, and then I'd like to hear from the rest of the panel is, do your trainees rotate through other clinical services in addition to VIR and their diagnostic rotations?
Yeah, so technically it's not IR, so I'll say neuro IR is one. They do 1 to 2 months in addition to the 1 month that's already mandatory for all residents at Loma Linda. So the neuro IR exposure is pretty good here, and they have clinic with them as well. Vascular surgery is 2 months minimum. They can do extra if they want. We're exploring cardiology because I'm working on building a multidisciplinary vascular practice with cardiology and vascular surgery here at Loma Linda. So that hasn't been set up yet, but I have my eye on it. Especially because we do some combo cases with electrophysiology, and I'd like them to spend some time in the EP clinic and see kind of what is required, or why do people even come in for battery exchanges and lead removals and things like that. So those are the main ones. My dream would be to do something similar to what we did at Ohio State back when I was a resident, which was I did GI, hepatobiliary surgery, med-onc, surg-onc. I mean, I was off radiology more than I was on radiology. I don't know how they accomplished that, but my dream would be to have them being on services that we interact with all the time and minimize the time that they're on radiology. But of course, in those first 3 years, you have to study, you have to learn the DR. It's very important to pass your boards as well. So.
On our end, I can jump in. I mentioned the integrated intern year, so they do get time spent on service with each of those services I mentioned previously. But I think ultimately, besides IR, our IR clinic is multidisciplinary. We have vascular surgery, vascular medicine, and IR in our heart and vascular clinic. So we're seeing patients side by side and see a lot of back and forth referrals from those services and that exchange. So there's that cross-pollination, even though it's not a dedicated vascular medicine rotation or time spent, but we work closely in addition to conferences. The only other rotation they do outside of IR and the required ICU is we do a palliative rotation. So there's pain management and palliative palliation. Dovetails well with our cancer practice and end-of-life management and pain and palliative care services, which we do actually a lot more than probably trainees recognize. A lot of what we do, whether it be pain procedures or tunnel drainage catheters, pleurex abdominal or chest, and obviously end-of-life discussions with the IO patients, we tend to be their doctors till the end of their life, and managing those sorts of things we've come to appreciate. That dedicated rotation has been really well received.
For us, so on our side of things, we also, just like Dr. Patel, we also have our internship year integrated into the 6 years. So our internship year residents actually particularly going to the specialties which are going to be interacting with VIR on a day-to-day basis, and specifically more so surgical and more aggressive subspecialties, of which I think we kind of have to start emulating a little bit more, given the nature of our specialty, if we really want to exist and be providing the same level of care. So our residents are going to surgical ICU during their internship. They're going to vascular surgery, transplant surgery, and they're going to general surgery, internal medicine for 1 month, hematology, oncology, GI, interventional cardiology. ER medicine is a must by ACGME, so they have to go for ER medicine anyways. And once they've cleared their internship year and they're during their categorical radiology and vascular intervention radiology realm, they also get to do additional vascular surgery months and surgical ICU months. In addition, they also go for neurointerventional surgery, where they're actually being our residents, when they graduate, they have complete numbers to be able to do a stroke and cardiac stenting. So they're also rotating through neurointervention radiology, and we are in the process of adding pediatric intervention radiology with Texas Children's Hospital, 40 minutes north of us, and also getting in contact with one of the OBL, so they can start getting the experience of what outpatient-based lab experience is like for vascular intervention radiology. So yeah, we try to, and starting next academic year, we're also adding dedicated podiatry rotation for our residents. So they will be going to podiatry 1 month a year, give or take.
How about Dr. V or Dr. Connor? Any pearls?
I mean, I think I kind of put in the chat, but basically, yeah, we're big into integration, right? So they do 2 months of CCU, 1 month of MICU, or 6 weeks of MICU, 1 month of stroke neurology, 3 months of neurointerventional. Some have done IC in the past, like Harut did, and I think you picked up a lot of pearls from the TAVR standpoint and the CTOs that they use. So a lot of overlap with the peripheral interventions that we do. So we've learned a lot. They do 80 hours of wound care clinic, so they pick that up as well. I think those are kind of the pearls that I've added. And we're always looking. We've sent them sometimes to clinics, to urology clinic, to urodynamics or whatever. So I think Zion's gone to hematology clinic for a half day, a week, et cetera. So things like that have added a lot of value. But 100% agree.
Okay, so the next question, first up for Dr. Saleem. What kinds of practice settings do your graduates practice in?
So it's actually a very good question. It's been mixed 50-50 percent. If I look at my last 6 or 7 years of graduates, because even if you take into account the fellowship years when fellowship used to exist, almost 50% of our graduates have gone into academic practices. That includes Mayo Clinic, UTMB itself, Mallinckrodt, Cleveland Clinic, Miami, and 50% of them have gone into private practice setups, both in smaller private practice groups and also big corporate practice groups as well. So if since the advent of our categorical integrated vascular intervention radiology residency, almost 70% of them have gone into academics. And I'm telling you, this year's 3 graduates, they're actually joining us UTMB. I myself was a graduate of UTMB. Year behind me, Irfan Masood, he stayed on. Year behind him, Farhan Ahmed, he stayed on at UTMB as well as an academic faculty. So the mix of faculty which has started going into academics and, so to speak, why UTMB also is because there has been a major cultural shift that had happened here at UTMB recently. And I think I continue to discuss this with Dr. Vatakencherry almost every week, so to speak, is that the rebranding of specialty in general. Like we have changed the pace of practice and the taste of practice as well, because prior to that was more so like a consult service and more radiologic interventional radiology kind of a practice where we were told this patient needs this particular procedure and this patient needs drain, this patient needs a biopsy and all of that. There has been a major shift from that to become more so like proper clinical service where we have started admitting our own patients, we have started our own clinic, we have started really functioning like a surgical service. And this year we actually gotten soft approval already. We submitted the name change as well, the rebranding of the division itself from vascular intervention radiology to endovascular and image guided surgery. And that practice model, that clinical model, actually does not really exist that much in the hyperspace as of right now. And I think it's bound to change the changes in about to be happening soon, because I'm seeing more and more, at least more and more academic practices moving more towards the clinical structure. And I think Dr. Patel and Dr. Vatakencherry were both the pioneers of that, and they can chip into that changing of this topic in greater detail. Given the fact when my graduates are graduating, and they've told me that they're not finding that practice model available to them out there in the country as much, other than academic practices. And even within academic practices, that model is not that prevalent. You will only find it at Dr. Patel's place, Dr. Vatakencherry's place, Dr. Cooper's place, Miami Vascular. These are just like very easily countable places where you can go and practice that kind of practice model. So maybe that was the effect. Uh, that was the backdrop of the trend that a lot of my graduates have started going more and more towards academic practices. And I invite all of my other panelists to speak about it too, because that's what I have noticed. And our program is very young. And why I say very young, it's a very old program, so to speak, but it's very young when it comes to clinical VIR or endovascular and image guided surgery, because we were not structured like that before. It's only been 2 to 3 years that we started practicing that model. And to be honest, if you ask me, I belong to the school, and my faculty cohort who joined me right behind me as well strongly belong to the fact that they are truly image guided surgeons who are forced to act like radiologists. There are more surgeons than there are radiologists. So,
All right, let's open that question up to our other panelists.
So Eric, the question was percent of graduates going into private practice versus academics? Was that the original question?
Yeah, just what sorts of practice settings are your graduates practicing in?
Yeah. So ours are, I would say 60-40, maybe 2/3, 1/3 private practice, and the smaller percentage into academics. Our 4 graduates this year are all going to private practice. They all have 100% or predominant 100% IR jobs. That's what they look for, frankly. And I know I've been hearing this around the country that it's been hard to find that, and I don't doubt that. But maybe it's a self-fulfilling prophecy. Some of the groups they're going to are practices that have some of our former graduates in there that have that model and understanding, are looking to grow their practices with that type of mindset and support. There are challenges. That's a larger discussion. You know, the DRIR challenges in outside of academics. My challenge, and I'll just pigtail onto what Arsalan was talking about, is I think that a large number of academic practices are ACGME certified or accredited, with the promise or expectation to give clinical training, and they're really not doing their best at that. I'm not here to name names, but I know for a fact you can hide in an academic practice with 100% IR, but that doesn't mean you're clinical, and doesn't mean you're 100% IR like most of us here on the panel do practice and expect to. And it's unfortunate because the new training programs are intended to design so that every clinic, every practice has clinic, every practice admits patients, every practice rounds. That's part of the training program. And we still hear at times that we need new, hungry, young faculty like Dr. Saleem to help bring that to their institution. So that's wonderful. And I think the training program at UTMB is head and shoulders better than it probably was years ago because of his efforts. But we need to see more of that. And I think you have to ask some good questions. And I see on the chat, I've been seeing that coming through, some really targeted and insightful questions to ask when you're looking at programs to train under, because just doing the cases isn't going to cut it. Being technically good isn't really the key anymore, and that won't ensure a long career. That's been said time and time again, but most of the programs you get training reside in academic institutions. So you have to be able to decipher which ones are really providing you a name on a certificate, or really solid training that you get to keep wherever you travel around the world or around the country.
So I'll be the dissenter. Well, not exactly, but my graduates have 100% all private practice, and most of them are 100% or near 100% IR. But it's not because they have to, it's because they want to. They, have children, big families, they want to keep their DR skills for later in their careers. And so I have a couple of graduates who have kept those DR relationships and enjoy it. And that's fine, because that's what they choose to do. It's not what they're being forced to do. And I think, when you look across the United States, depending on where you're from, smaller rural states in the Midwest, like Oklahoma, you have very limited numbers of 100% academic IR, and that's okay. You know, but there has to be pros and cons. And so my non-academic partners throughout the state make probably twice as much money as I do, and mostly do 80 to 90% IR. And that's okay because they have great practices. They're still doing extremely clinical IR. They're still doing extremely clinical things and doing exceedingly exciting procedures at transplant centers and trauma centers. So, you know, it's not the killer, you know, if it's not 100% IR, because there's, yeah, I think, again, to be the dissenter, if you're not looking at that, then you might be missing some great jobs out there across the country that might have great lifestyles. They might have great practices that have a lot of resources. So yeah, I'll be the dissenter on that one.
Yeah, I want to push back and say that it wasn't because they need to do 100% IR. That's what they wanted to do as well. My issue with non 100% IR jobs isn't that they're not doing all IR. It's that sometimes those individuals, either by practice or by sort of choice or overall, evolve in their careers to being less clinical. And that's the concern I have. If you do 50% IR and 50% DR because you're in a rural area of the country that can't support 100% IR practice, frankly, but you're doing it clinical, you have a clinic, you see patients, you longitudinally follow them up, you see consults, and you treat your IR portion of your practice that way, then that's great. And I think that we have to be understanding for those who don't do 100% IR. I just don't have a lot of particular tolerance for non-clinical IR practices. It's not about 100% IR, because there's a lot of 100% IRs who don't do clinical practice either, and that's not any good either.
Yeah, I have to echo that statement. I've seen this unfortunately time and time again, even in our system, where patients are dropped. They're abandoned because they're not followed by VIRs. It takes a lot of effort to do clinic and follow these patients. It ain't easy. The amount of emails and messages I'm getting is like nonstop. I've gone from half a day every other week of clinic to a day and a half to 2 days. And quite frankly, that's not enough now. So just like every other clinician, now that I've kind of established it, I've realized all the errors I've made in the last 15 years and how many patients I've hurt because of inadequate care. And that has to stop from our specialty. Honestly, it has to stop somehow. We can't build these 50-50 years thinking that they're providing quality care, and be honest to our patients. If that was my family member, and I'll tell you an example, this happened to a family member of mine close to me where they didn't follow the drain. You know, and it was sad. And I was very angry at that person, right? I mean, they're in the part-time practice. Yeah, their lifestyle is great, but they didn't do the due diligence as a surgeon to follow my family member. The amount of, like, I was embarrassed to be an interventionalist after seeing that my own family member, very close to me, dear to my heart, treated that way by an IR, well trained, I'm sure. But just have the decency to follow your patients and write a note and talk to the family, because it was a serious thing at that during my developmental years as a med student to see that, and I was frankly disappointed. So I agree with Dr. Patel. We have a responsibility to the patients and the public to provide not a comprehensive clinical care and do the right thing. Right now, we're not doing that. And we need to change our structure so that we can do that. It really is, it's become an ethical thing for me now. Should VIR exist as it is right now or not? And part of me is like, maybe we train surgeons to do what we do. The other is like, let's do it the right way, recruit right people and train them properly and get them to jobs that enable them to do that. You know, so as I get more senior, I'm like, I'm more focused on the public and the patients than I am the specialty, to be honest with you. Just, I've changed my whole amalgam on thinking on that. I'm not as protectionist as I used to be. Let's put it that way.
I agree with that, Georgie. I fully agree with that. Yeah.
We've been rapidly expanding our practice, gone from 5 attendings when I started at Loma Linda to 10 next year. And so we hired several of our residents, all of them, I would say they're 100% IR and then an additional 10% DR that they put on top of it, that there are moonlighting opportunities for them to keep their DR skills here. So they work their full practice and then they get to do DR on the side for extra cash. So I'm fine with that. But I agree, in the years prior to the last two, we were about 50-50 IR and DR, and but all of the academic and private practice, I'm sorry. But the private practice jobs were, I would only allow them to interview if they were highly clinical. So I agree with everything Dr. Patel said.
As a follow-up, so we mentioned most programs say they're clinical, but in practice might not actually be. So to each of our panelists, if you could ask each program one question to assess if they're actually the, pinnacle of clinical practice, what would that question be?
I think it's how does I said this in the chat, but how does the patient end up on your procedure table? Can people order procedures, or is every single thing a consult? And is every patient after their procedure done followed? I mean, that's how do they get on the table, and how do you ensure that they get good follow-up after the procedure?
Might say, my question would be, are you admitting your own patient or not? Yeah. Are you admitting your own patient straight from ER? And are you admitting, because our SICU is an open SICU, so are you parking your patients in SICU? Are you managing your care in SICU or not? And that answers it all. Because if you're admitting your own patient, then for sure you're also seeing them in your clinic. And if you're admitting your own patients, then for sure you're known in the hospital system. You're an admitting service, you're a full clinical service, and ER trusts you enough, other services trust you enough to have that privilege and get them admitted, and then you can consult other services, the other important thing is what Dr. Cooper just mentioned is, are they ordering procedures? Are they ordering you to do a procedure, or they're consulting you for your opinion and your evaluation? And that was just like a golden sentence that he just threw it right there moments ago.
Yeah, and I do think as evidence in our thing, as the residents start doing clinic and consults on a continuous basis as a resident, it'll feel dirty to do an order entry procedure, right? It really will. Like I feel so dirty even now if I do a thyroid biopsy and the patient's like freaking out unless I talk to him for 5 minutes about it. Going like I could do a complex EVAR or whatever, and I like they're not scared at all. And I went to the ASU, which I'd never cover, and I hadn't talked to some of these patients beforehand, and they were freaking out about a thyroid biopsy. I'm like, oh my God. And so I haven't felt that in so long that I felt dirty. I'm like, I'm not doing that anymore. Just put in to have a telehealth. I'll talk to them for 5 minutes or 10 minutes. At least they'll be a little bit more comfortable when I'm seeing them. So even for me, just recently, last 6 months, I went back to that old model and it just felt dirty. So I think as trainees start to incorporate this early on, just like any other specialty, it just feels wrong.
And I think some people can still hide behind the consult question as well. I mean, you can build into Epic a consult, but you can make a consult easily orderable. So one thing that I found is that in full disclosure, I'm on the review committee for ACGME. I'm not representing the ACGME, but I see a lot of different programs. And one question I would ask is, go beyond that consult question, because people can still hide behind that. They can still hide behind the clinic question as well. They might have a nurse practitioner doing a virtual clinic, and the residents and the attendings actually aren't in the clinic much, just a token clinic, or even, they might have a small office next door to a procedure room, and that's their clinic. So you really need to ask specific questions about clinic. But the thing that I really think sets clinicians apart is I know what the long-term patency of my tips are. I know what the results of my liver-directed therapies are. If it's just a conveyor belt IR practice where they may be saying the right words about clinic, they might be saying the right words about admitting or whatever, and every practice is different. It doesn't have to be clinic admitting. It doesn't have to be this, that, and the other. It's not a cookie cutter process. Every practice is different. But if they're just doing the procedure and they didn't round on the patient the next day, they didn't see the patient in clinic a week later, or even do a phone call, and they have no idea if that patient is dead, but they got those RVUs, then that's not a clinical service.
Yeah, I'd like to add on to that, Keri. Those are excellent points. When we first implemented the IR residency, we had a special committee that was reviewing all the IR components of such. So we did a lot of that for every program when we first started this years back. And so an astute eye by an IR like yourself, when you look at a program, is really important. And I think that's the key here for all of the in the audience, the trainees. the academic programs or where most of the training programs reside can all say the right buzzwords. They know what to say. I don't take back what I said earlier about some of them still not really meeting what I think is the criterion for clinical, but I also understand how we define clinical can be different, even amongst all of us on the panel, although I don't doubt anyone is not doing clinical work here. But to that point, is clinic wholly run by an APP? Have they outsourced all of that and not taking the ownership of the patient? These are great questions. Is 100% of the patients seen in clinic result in a procedure? Now think about that. If every patient you see in clinic results in a liver-directed therapy, if every patient in clinic results in a peripheral intervention, if every clinic and patient results in a TIPS, then I would argue your referring doctors have already determined the treatment for you, and it's just a glorified consent clinic. Because if you're seeing patients and you're managing the disease state and portal hypertension and saying, you know, what, you're really not a candidate for TIPS, and they'll call the hepatologist or I'll let the referring doctor know, and I'm going to suggest something else alternative. Now you're actually the doctor who's an expert in the disease state, and you're actually managing that. So some of your patients are going to be new patients. Some of them are going to be follow-ups. How much are the attending seeing those patients in clinic? What percent are, our longitudinal care follow-up? Are they rounding on patients? Are the APPs doing rounding on patients? Our practice has been pretty clinical from the onset, at least since I started there. And not until just a year ago did we hire, and we've had clinic ever since I've started from day one, not until a year and a half ago did we hire an APP to help us in clinic. Prior to that, it was only the attendings who saw patients in clinic. We owned that practice. That was critical for us for building the different areas in which we wanted to build, and we still own that in that regard. But the volumes have grown so high that we need some help and support in some of our follow-ups, and we've now done what I think a lot of other practices have done to good effect. But it's not their primary role; it's our primary role.
Yeah, we have APPs in our clinic setting and in our procedural setting, but it's because we have basically taken all of the procedural everything. And so we train APPs to do a lot of those things that actually your surgical colleagues no longer do, a good chest tube or a good, paracentesis. And while I love doing those things, I can't do all of them. And so APPs in our environment really help offload the, quote unquote scut work for the residents so they can truly spend some extra time before, once you get ramped up. And that was probably the biggest thing I learned at Miami Vascular was how to work fast and how to work and practically and efficiently. And if you're doing a lot of, scut or really not getting to spend time clinically with your patients, and I think in the integrated programs, you have to ask these questions. What are those residents getting to do in those early years? Because again, we see some programs that it's almost like they're a diagnostic radiology resident the entire time. And then it's the old fellowship still tagged on. I might even ask the program director, what do you do for your MAMs, or what do you do for your nukes, and how many people do those things afterwards, and try to get a feel for how involved they are in those PGY 2 through 4 years, because they may not really have a good idea. If they're really invested in that program, they will know those other things that are actually outside the IR armamentarium as well.
Awesome discussion. All right. Last question. This one we'll start with Dr. Connor. How can trainees hone their practice building skills during residency and fellowship?
Well, that's a really broad question. How can you hone it? I think, just what I just said, you have to be as efficient as possible, and really these years, even integrated, and especially for independent, especially, is once you get into those really clinical times, you just have to really work as hard as you can, because even, with the recent changes with our ACGME changes with integrated and independent, it goes so quickly. And I think you need to be really cognizant of what you want out of it and what kind of practice. I mean, even when I have surgery interns or medicine interns, what kind of practice do you want? I mean, you need to be looking forward and not just, hanging out and doing, whatever it is that they want you to do, but you need to look, am I going into a private practice? Do I want to stay where my family is? Do I want to travel? Do I want to look into, taking stroke call? Do I want to do all these different things? would I like to start an OBL? Do I want to be part of an OBL? You know, you really need to look at what it is you want to get out of your job, and then, you know, backtrack a little bit and make sure that you really get the most out of your training. And, you know, if you're missing some things, you really need to maybe ask for those things. You know, if you didn't get enough neuro, you didn't get enough procedures on your neuro rotations, I mean, you really need to probably keep as good of logs. I would say logs are really important, you know, when you're looking forward at what you're doing. You know, some programs are great and they're going to give you everything you need, but not every program's like that. I think you really have to advocate for yourself and advocate for what you're looking for, because this is a job. You know, you get paid, training is a job, but it is, you know, the job before the real job. So you really need to take everything you can out of the job you have before you get the job that you're really looking for.
Do we have any input from our other panelists?
Those are great points, Dr. Connor shared. I would, you know, as far as practice building goes, I think you want to start to emulate some of the things you'll end up doing in practice, you know, your first year out. One of the things I always tell our trainees is communication. You know, we talk about, you know, being available, affable, and ability, those qualities. But part of that is that a little bit of that closed loop communication. Every time they do a procedure, I say communicate to the team, you know, whether it's your co-resident on the other service, or perhaps, you know, maybe it's not direct to an attending a communication. But what I do on my patients that I treat with someone is I let them know either via some hospital communication or even by a phone call and say, hey, I just saw, you know, Mrs. H today, and she's doing great. Look, you know, some symptoms have resolved or wound is healed, whatever it is I was managing her for. And I like to make sure that they connect, you know, my care for their patient with me. And I still do that to this day. And I tell them to do the same thing. It's easier probably done on the inpatient side, but they're frequently are identifying patients that they can take care of or help when they're on other services, and communicating back with their team ends up, you know, resulting in other consults or other referrals for other things. And so learning to do that now and not trying to flip the switch when you're in practice to say, okay, now I'll start to remember to call or follow up with the referring doctor with who I took care of a patient. The same thing is done on rounds, right? When you're rounding on a patient in the SICU who's a trauma patient who you did a, you know, post traumatic embolization on, and you're rounding on them and making sure that they, you know, the patient's doing well and no more bleeding, hemodynamically stable, recovering well. You know, why would you not want to take some of that credit by rounding on that patient, making sure they're doing well and connecting with the referring service? So I think those are things that are part and parcel to being clinical, but also actually being cognizant that that is part of practice building, showing them that you're present, available, taking care of the patients and the outcomes you're getting.
Yeah, I mean, I have to echo that. This is something that I've recognized that I tell my graduates, look, I know you're very good technically. You can do these PAD cases, EVARs, prostates, whatever. Like, I don't care about that. You're pretty solid in clinic. Great. You're decent in consults. You're strong in the intensive care unit. But I tell them you will not succeed when you graduate if you don't know how to practice build and, more importantly, navigate the politics. Teaching them about politics is exceedingly hard. All right, it's situational awareness. It's a lot of nuances. It's very difficult because you have to know all the players in depth, and it's hard. Like, you have to know all these people on this conference call to really understand the politics. It's challenging. So I make sure I go, hey, and I bug them, like, what did you do to practice build this week? And there's no excuse that you're on DR and you can't practice build. So Austin got an aneurysm. Good. I'm like, you know, you got an aneurysm to his clinic. So from DR, right? So you got to practice build it. If you're in the gym or you're in the cafeteria, you bump into a medicine resident or PEDS resident, you tell them what you can do. And hey, are you going to send me a referral to my clinic?
And
There's
call.
no excuse.
And
Yeah.
call. Yeah.
100% call them. Don't even text them and tell them. Don't even just call them and talk to them, right? And I've even had them now go to the FP residence and give a talk on PAD. So Zaim's going to, or Anoop's going to do that. So these things are invaluable, right? And then just having them go to the other clinics to educate on what we do, also helpful. So the clinic is the cornerstone. The more you get patients in your clinic and the more they get their own referrals to their clinic, that's going to be a guarantee of success. If they don't, I tell them they're going to fail. It's the truth. If they get to as a resident, when you know all these house staff and you're in this environment that you've been there for 6 years, If you can't get a patient in clinic, sorry, you're not going to succeed when you get out.
Make those phone calls, because once, if you know your primary care is your family medicine, your internal medicine, your hospitalist, your continuity of care practitioners, if you make that a habit during your residency, you're going to make it a habit during practice. And I guarantee you, they will send you patients. And that referral process is the most important thing. They're, if it's PAD, they can send it to us, they can send it to a cardiologist, they can send it to, I don't know, a vein person, they can send it to a vascular surgeon, but who are they going to send it to? They're going to send it to the person who they have in their phone and who they know is going to see those patients quickly.
Yeah. I think I can't stress on this and agree with this enough, which Dr. Patel and Dr. Connor just mentioned. Communication closing the loop is the key. And I'll give you an example. 2 years ago, a year and a half ago, we, as VIR department, we were not doing any of the venous work or any of the kyphoplasties. And the only thing that we did, and I talked to my partners, we were just two at that time, and we were three now, is that every time we will get a consult and we'll do a procedure, we'll send them a detailed text with a picture and sometimes call. Like, hey, this is the day I saw your patient, and I'm doing the procedure this day, and this was the pain score right before the procedure. This was the pain score right after the procedure, and this is the day I'm going to be seeing your patient. These are the pictures. And then sometimes give them a call. And right now, almost 100% of vertebroplasties are coming to VIR. And some of the emails coming from anesthesia pain department about why they're going, all of them are going to VIR. So that's just one example that we saw. And we started doing this for all of our patients, all of our care that we are doing right now. My chief residents in my PGY 6 and 5, they absolutely always are sending messages, text messages, to confirm with the referring provider that this was your patient, you've taken care of it, and they're doing great, and we'll be seeing more clinic on this day.
I think at the end of the day, the thing that always guides me is that I do what's right for the patient, and I try to treat each patient how I would want to be treated. It makes it easy. That's all you have to do.
Well, it looks like we're kind of wrapping up on our program director panel time here, but just want to thank all of you for joining us.
I met an FN.
Getting someone else on here. Oh, so it looks like, I think this is the best program director panel I've ever heard. And, I hope all the trainees on here agree with me. I think these are the conversations we need to be having, and we need, our residents and medical students to be hearing these things before we enter our training. And, the conversation today just makes me even more excited to go after that. So thank you very much, and let's get on to the rest of our programming.
Thank you.
Thanks. Good luck, everyone.
Thank you so much. Yeah.
Thanks for having us. And good luck in the match for those that are soon matching.